All right, we're going to begin this assessment. First observation, my patient would be properly clothed in a gown, properly draped. For the purpose of this, we're going to use clothes. Vital signs would be my first thing. While checking the radial pulse, I would be checking for the breathing, rate, rhythm, depth, regularity. Count for a full 15 seconds. I'd move on to inspecting the chest anterior and posteriorly, making sure that we have a normal anterior posterior diameter with no barrel chest. Check the skin for any obvious lesions. Move on to auscultation. Use my auscultation while I'm also more closely observing, having the patient take deep breaths each time I move my stethoscope, alternating sides so that I can check each lobe, making sure to go all the way around to the mid-axillary lines so that I can catch the middle lobe. Breath sounds are vesicular in the bases, bronchovesicular near the midline. Check the patient for fremitus by having the patient speak while my hand is against the back.
99, 99, 99, 99.
Any areas of dullness
99.
would indicate inclusion. After that, I would go to percussing by placing my hand and tapping my finger, hearing a nice resonant note, alternating sides to check for balance. When I get to dullness, I know I've hit the edge of the liver. Going around behind my patient to check for expansion of the lungs by having my patient exhale deeply and then inhale deeply so that I can feel the expansion of the lungs. Go ahead and exhale. Thank you. Filling lungs to the bases. I'm going to check the carotid pulses. And check one side at a time to ensure no blockage. Checking it gently so as not to stimulate the vagal nerve. We have a good carotid pulse, 2+ on each side. It's brisk. Using the bell of the stethoscope, I'm going to check for bruits. By lightly applying the bell to the neck. There are no bruits present. I'm going to have my patient go ahead and lay down so that I can more better examine the chest. The first observation, use palpation, checking for any areas of lumps or tenderness, also checking for symmetry. There's a mild area of tenderness along the 5th intercostal space. Could use some further examination. Check for tactile fremitus also on the front using the same technique, having the patient speak.
99, 99, 99, 99.
Tactile fremitus present in all areas. Also percussing the front. Alternating sides with resonant notes. Dullness indicates that I have reached the borders of the liver. Begin with auscultating the breath sounds by having the patient taking in deep breaths, mainly bronchovesicular sounds, until I reach the lower bases where I anticipate hearing vesicular breath sounds. Moving on to auscultate the heart sounds by having the patient breathe normally, starting at the second intercostal space. Checking for S1 and S2. Present and clear. Heart rate is normal. Using the bell of the stethoscope. Start down here at the apex, lightly applying the stethoscope over the apex, listening for murmurs and clicks. Following up the sternal border. No clicks or murmurs present. Checking the pulses. Brachial pulse, which is present. Radial pulse. Wrist capillary refill. You're going to skip the femoral pulse at this point in time and move on down to the popliteal pulse, raising the patient's leg, pressing the fingers together under the knee. The good 2+ popliteal pulse. No varicosities present on the leg. Checking the dorsal pedalis pulse, also 2+. And the posterior tibial pulse, 2+. Wrist capillary refill, both feet. Again, checking the pulses, dorsal pedalis, posterior tibial, popliteal. Again, checking for varicosities during the exam, none present. Always using the pads of the fingers. Brachial pulse, 2+. This concludes our examination.